kicking us off. Inga mana, inga reo, rau rangatira mā, tēnā koutou, tēnā koutou, tēnā koutou katoa. Welcome to the Collaborative Aotearoa webinar on Mana Enhancing Debt Management. It's a pleasure to open up our hui, and I'll open us up with a karakia today and then introduce you to our panellists. Me mahi tahi mātou, ka kōrero, ka whakarongo, kia atawhai, kia manaki mō ngā whānau me ngā hāpuri katoa, kia rātou te tino rangatiratanga I o rātou hauora. Kia pai te taha tinana, te taha wairoa, te taha whānau, me te taha hineraro poki. Haumi e, hui e, tai ki e. Pleasure to be here with you all this afternoon to talk about what's one of the most confronting issues in general practice at the moment, with patient debt getting worse by the day and becoming one of those things that's keeping our administrators, our practice managers, our business managers and business owners up at night. So debt management poses a formidable burden on our general practices at the moment, casting a shadow over both patients and healthcare providers. We wanted to lean into that. We wanted to provide a forum to support practices to understand what you can do to support patients with debt management within your practice, to provide that I guess that little bit of solution, innovation, sharing of ideas and collaboration, and enable maybe some different approaches to be shared across our network. Thanks for taking the time today. It's great to have everyone here to share this time with us. We are going to take a proactive stance, centering around preventative measures and placing people at the centre, making sure that everything that we do in general practice is around our whānau and the people that we are serving. So on our panel today, we've got a kick-ass lineup for you. I don't know if I'm allowed to say that online, but we've got some beautiful people here to share their whakaaro. They've been people that have worked in general practice, that work with people with debt, that know a lot about our system and a lot about all of the challenges that we face, and really excited to hear them. So we're going to quickly introduce, I'm going to quickly just name our panelists, and then what we'll do is we'll get them to open with an opening question, and while I'm introducing them, we'll let them ponder the opening question. So the pātai for all of our panelists when you're introducing yourself to the rōpū is, what practical tips can you share with the rōpū here today around patient-centred debt management? So what have you seen practices do, and what's the positive impacts that you've seen around patient debt management? So we're just going to get straight in with the crux of the questioning and go in nice and hot off the top. So that's a question. What have you seen that's worked? What are the tools and resources that you think are the most important things for people to know about? So we've got Heidi here from the college. Everyone knows Heidi from the college. Kia ora, Heidi. We've got Karoria from Collaborative Aotearoa here. So Karoria is on the CoLab board, and she's one of our lived experience advisors, so going to bring that patient lens to our kōrero today. Lisa is here from Three Rivers Medical, and then we've got Heather and Kathy here from MSD, so really excited to be collabing with the Ministry of Social Development here today, and also leaning into all of your knowledge in this space. And then we've got Nee from Team Collaborative Aotearoa as well. Nee's one of my colleagues at CoLab, and has also spent a lot of her career working in debt management and general practice, so going to be bringing some of her whakaaro to the ground today. But to kick us off, the question is, what practical tips can you share where patient-centred debt management is at the centre? So what have you got to bring to the table in terms of today's discussion? We're going to start in my top left corner. So Kathy, we'll kick off with you, and then we'll pass the rākau around the other panellists.
Kia ora tātou, ko Kathy Stevenson, tōku ingoa. Thank you, Jess, for the lovely introduction. And it's, a real privilege to be here sitting amongst such wonderful wahine, an all-female panel, which is fantastic. I am Principal Health Advisor at Ministry of Social Development. I'm also a GP in a Pororua clinic called the 502, which is a Rangatahi Ora clinic, as part of the Ngāti Toa services there. And I have also got COVID at the moment. So if I seem a little bit fuddled, please forgive me, which is why I've invited my really wonderful colleague Heather to step in if my answers aren't making sense. So Heather, it will be, yes, your job to remove me from the screen if I'm saying things I shouldn't be, and I'll blame COVID. I think in answer to the question, I suppose from my clinical experience working in a very high needs region with some pretty vulnerable young people, I would encourage you, where possible, to not let the debt side of things interfere with the care. And I know that that's really, really difficult when you're in a business model, but I have seen people not come back because they're fearful about that, miss out on important healthcare for them and their whānau, and then the health needs get worse and worse and worse and more complicated. So where possible, that prevention approach, I think, is better than cure where we can, and to reach out to MSD, and we'll give you some ways that you can do that later on in the hui, because we can and often will be able to help in lots and lots of situations. So I guess that's in a nutshell from me, really.
Kia ora, Kathy. We'll go over to you, Heidi. Kia ora, Heidi.
Kia ora koutou, everybody. Ko Heidi tōku ingoa. I work for the Royal College of General Practitioners and am the principal advisor to the quality programs. But before that, a lengthy stint in primary care and general practice, and a high needs centre for about 20 years, first of all as a practice nurse, then as a practice manager and practice nurse. And so, yes, so one thing that springs to mind, we had a lot of debt in our practice. One thing that I remember that worked very well for one family is they had a massive debt, but they also had a lot of health anxiety. So they were coming to the doctor with their whānau almost daily, and they couldn't pay. So the debt just kept mounting up. So having a conversation with her and really discovering what was going on for her, we put some measures in place where she had access to nurses at any time, or me, for a triage, just to check out whether she really needed to come to the doctor or not. That gave her reassurance, and she was quite happy with that. The number of consultations went down, and then other measures we put in place meant that she was managing to actually pay off her debt. So so that was one of my examples. So today I'm really going to come in from the angle of the quality programs and the foundation standard, and talk through that lens around this issue here. So thanks for having me today.
Kia ora, Heidi. What a great example to kick us off with, and I think it really leans into the value of population stratification, which Nii and I have just spent all morning talking about, but using that data to really inform the way in which we work in our general practices. And I think that that's a really good example of looking at those people who are coming in a lot of the time and what are they needing to be seen for, and can we put better plans and measures in place to support them in accessing general practice. A beautiful example of how we can support patients in this space. Kia ora e hoa.
Kia ora koutou. Thank you for having me. My name is Nii Brunenberg, and I'm currently the Digital Health Change Lead at Collaborative Aotearoa, based in Wellington. I have a background in banking, so that's in the customer care and recovery space. I worked quite a bit in the general practice space and PHO, and recently I see myself a champion in sort of that patient-centered approaches, and have played sort of key roles in facilitating quality accreditation programs with Heidi at the college, and implementing the healthcare home model of care, and really sort of supporting that patient experience. So I guess from the lens of working in general practice and my stint in banking, the only sort of tips and practical I guess, tricks that I can probably offer from what I think I can see that sort of could work in a very good environment, in a very big or small community, would be having some sort of pay it forward initiative in the practice. Maybe, you know, if you've got a practice that has a patient that's coming in that particular day that they all owe a certain amount of money, having frontline saying, look, we've got this pay it forward sort of scheme, would you be wanting to pay a debt? People do it in supermarkets, they pay for their, you know, the people in front of them, their shopping, and having that sort of community approach, I feel, could help share that love and that support, and see debt as more of a helping mechanism instead of a negative sort of whakamā thing that you don't want to talk about, and making it sort of very visible and very honest at the forefront to say that we've got people in debt, would you be willing to help pay it forward? So that's my tip, I would say.
No. Kia ora, that's awesome. Heather, kia ora.
Ora koutou, ko Heather Harding tako ingoa. Unlike Kathy, I don't have COVID, but I have had a cold and a wee bit of laryngitis, so hopefully we can manage to pull this off between us. I'm a regional health advisor with the Ministry of Social Development, or work and income, in sunny at the moment, Canterbury. Currently seconded to work with Kathy in National Office up until the end of June. My one tip, I guess, would be to, if you don't already have an established relationship with your health and disability team in your region for work and income, that you foster that and encourage that, because they, particularly our health and disability coordinators, they are a nice step into our system, so that you don't need to be on the 0800 number. And we can help you in all kinds of ways, as Kathy has said, but it's a much more personal and quick way for you to be able to access us. It doesn't have to be the doctor, it could be the nurse, it could be the health coach, might be the HIP or the practice manager. So however you need to do that, we are available to you as a resource. So yeah, happy to help. Thank you.
Thanks, Heather. And going into the Gemba of General Practice, Lisa, kia ora, welcome to our forum.
Kia ora koutou, Lisa Hamblin from Three Rivers Medical in Gisborne. I'm born and raised in Tairāwhiti, so yeah, almost 50 years, and I've been in general practice for almost 30 years now. So in one admin role or another, office junior, reception, and then I fell into the operations management role a few years ago. For me, practical tips. So I think it actually starts before the practical tips. So for me, it's trying to have an environment that is comfortable, welcoming, and without bias or judgment. So that's your core basis, and I think that also trying to get into those conversations, but from a connection point of view. So making sure you connect with the person, they understand that, you know, it's probably not a conversation you really want to be having, but it's necessary, and you want to help. And you want to assist in any way. I think a lot of it comes down to how you approach it. You don't want to be condescending, but you certainly want to be making sure that people know that you're coming from a place of goodness, basically, you know, for a situation that, you know, facts are facts. There is a co-payment, and yeah, so we've had some success with a lot of our patients starting automatic payments, either through MSD or out of their own bank accounts, and it makes a huge difference to those people, because they almost feel empowered, and that's where we're trying to get. And it's a lot of admin for us. There's a lot of admin, pages and pages of entries of bank statements, but the payoff is worth it in the end. You know, we've also got our media, so they can pay online as well through a pay by link. People are a little bit suspicious about links at the moment, which is tricky, but that's made things a lot easier as well. But I certainly think that the way you approach it is one of the more important things. Yeah. Thank you.
Oh, that's beautiful. That's some really good examples there, Lisa, around how you can do that. I love how you brought us right back to that environment and how that makes you feel, and to elaborate, I'm sure, on that, and to lean into that patient perspective. Kororia, welcome to our forum. Introduce yourself to our rōpū, and yeah, share with us some of the things that as a patient you'd like to see practices doing.
Tēnā koe, Jess, kia mihi, kia koutou katoa, ko waio, ko Ngāpui te rarawa me te apaurina iwi, ko Cable Bay tai tukero, tuka kainga i nāianei, ko te whare tapu Ngāpui tuka tūranga waiwai, ko Karuri Johns kia hau, tēnā koutou, tēnā koutou, tēnā koutou katoa. Kia ora, I'm Kororia. You heard a little bit about my bio before, but I really just want to initially meet particularly to Lisa. I love all the whakaaro, but particularly to you, Lisa, because I think that underpinning all of this is maintaining those trusted relationships that allow meaningful, impactful connection with our whānau. And my consideration when I was thinking about this pātai was, I'm not a patient, I'm a person. And I've got a whānau, and I've got, you know, I've got someone who needs care, but I've got this whakamara about going in because although I might have chatted to the accounts lady, I know the receptionist might haul me up when I'm in the reception area and those kinds of things. So it might stop me getting care. So I just, I guess I just wanted to invite a bit of consideration around that, connecting with a person first and discussing what their challenges are, because particularly in my rohe, in my whānau, these people are survivors, right? They've got sometimes very complex ways through, but they do have strategies, and allowing them to shoulder some of the solution, I guess, and inviting their consideration, and just being clear about what the considerations are for you, and invites that kind of empathy. And suddenly there's a strengthening of that relationship, even though the topic might be a bit challenging at times. If you're sticking to the facts and you're inviting their input and their considerations, I think they will, you know, sometimes we've got resources at our disposal that might support their strategies. Take the pie, right? It's a in the kupu empowerment, I appreciate that as a sector we use that, but if I take my sector hat off and put my whānau hat on, I often find it kind of condescending when people talk about my empowerment. What I really want to experience when I'm not in the thinking place and I'm in the feeling place, what I want to experience is a sense of activation, because I can get behind that and I can get on board with that, and that puts me in a position where I'm driving and right. So just what's the experience like for whānau, I guess, would be the things that I would be considering, and sometimes just slowing down a minute to step forward can actually make us go a lot quicker. So that would be my initial kind of instinctual reaction to this pātai, but great pātai. Kia ora tātou.
Kia ora. Well, to kick us off, we've had 6 top tips to get us going and get the kind of thoughts flowing and the ideas going. If you do have questions specifically for one of our panelists or all of our panelists, feel free to pop them into the chat. We will be just asking them as we go. So if there's some goodies that come in there, I will fast forward them on the question list and we'll get those answered for you. So do feel free to interact with our Q&A function on at the top. It's just the little button with the question mark in it. I think to kind of wrap up the practical tools and some of that kōrero that we've had, I've been recently interviewing a whole lot of whānau for my research that I'm doing, and one of the questions that I asked talk about, you know, what enables you to go to your doctor. And one practice in Tai Tokerau don't charge their patients to go to the doctor. It's a fees-free model that the trust run. And a patient from that model said to me, Well, because my practice doesn't charge me and it's free for me to go to the doctors, I go when I'm just a little bit sick, not when I'm really unwell. And I think that sometimes the reality, a lot of the people coming in and seeing us within general practice, and it was quite a compelling, quite a confronting statement from a whānau that I interviewed that kind of, you know, really put it out there to say, well, actually, when I'm hit with this price of going to the doctors, which has increased and increased over the years, I have to really assess whether I'm really going to go or not. And then we know that disadvantages some of our population more than others, and definitely makes it harder for some of our population to access. So being able to create those environments where our patients do want to come in and see our care teams, we are using our extended care teams to really support with that wider access into general practice are really important things for us to consider and do. So now we're going to pick on some individuals. We're going to do some little one-on-one questioning, or a duo. So Kathy and Heather, we're kicking off with you guys. Your question is, where can health providers go for more information and resources when they are providing care for patients who are accessing work and income supports?
Thank you. Heather, I'll kick off and then hand to you if that works. And look, as a GP who's only been in the work and income role for about a year and a half, I know that until I moved into the work and income space, I only knew, honestly, the tip of the iceberg in terms of supports and services that could be offered for whānau. So there is a lot of resource sitting within MSD and work and income. And I think sometimes at primary care, it's really hard to know where to go to find out what might be available for a particular patient or a particular whānau. So the first thing, and probably the most important thing, is to reach out to your regional health and disability team. I've just put my email in the Q&A and Heather will put hers in too. If you don't know who your regional health and disability team are, email us and we'll send you the list. They're not publicly facing contacts because we can't give those to clients. There simply aren't enough of our advisors to be able to be client facing. So they are just for health providers, but I'm really happy to share them with you. And each region has a regional health advisor. So Heather is the Canterbury one, a regional disability advisor and a health and disability coordinator. And their role is to connect with you, make sure you understand and your practice team understands all the supports and services we've got for whānau, but also just to provide you with resources as well. So if you want, for example, the name and number of a local employment coordinator or work service that we could potentially link a patient of yours with, we can provide you with that. If you want specific information around what a patient may or may not be eligible and entitled to, we can support your GPs and your nurses with that. Or if you want extra copies of forms and leaflets and that kind of thing, we can do that too. So our regional health and disability teams are an amazing resource for you and they are there for you. Their role is to connect with primary care. So please reach out and invite them into your practice. They've got capacity to visit practices, particularly the coordinators. So, you know, if you have regular practice team meetings, bring them along. It's a great way to whaka whanauna and start building those relationships with MSD. So that's probably the first thing. In terms of an actual resource that you can go to find out information. On our website, there is a page called Health and Disability Practitioners Information. I can put the link up in the Q&A as well. And that's like a sort of online handbook, really, that will talk your practitioners through what our different levels of benefit are, what costs can come under things like disability allowance and child disability allowance, what forms to fill in when, and where to go for more advice. So we can put that page of our website up there as well. And we are in the final stages of getting a health pathway up onto your wonderful regional health pathways for work and income. So that should be live and online within the next couple of months. And that will just sit in your normal community health pathways and should be a kind of overview of everything that's available for work and income for your patients. Heather, is there other stuff that I have missed out there?
So one of the things I've got on my list is health pathways. So there, do you want to have a wee chat about that one, Kathy, around the page that's coming? There is some information, I think, on regional pages currently. I know that Canterbury has some information around funding and what's the types of things that we can you can access via funding via work and income. But I know that there's a more overarching national one coming up, isn't it, Kathy?
Yep. Yeah, which should be hopefully available in the next month or two. We're just waiting for the final authoring of that bit.
So that's another link that you potentially could be tapping into. And on the Work and Income website, you may have seen it on the front page. There's a button called Check What You Might Get, and that's something that your patients can access themselves from the privacy of their own home if they don't want to be doing it anywhere else. And it's a reasonably quick questionnaire, and it will ask them all kinds of questions about their circumstances, and in particular around health and disability. And it will then, at the end of that, will give them an indication of what they may be entitled to and how they would go about applying for those either benefits or allowances. So that can be quite a good snapshot in a reasonably short time frame. And as I say, it's good because they can do it in the privacy of their own home, and it will ask them. So it might be that you have a low income earner that potentially isn't accessing all the help that they might be able to get. So that might be somewhere that you could point them just to kind of check if there's any other assistance they might be entitled to. And I guess when you're providing information, say on one of our medical certificates, or you're writing a letter for one of your patients, etc., as much information as you can possibly give is absolutely best for us. So we don't have to keep coming backwards and forwards and annoying and those sorts of things. So as much information as you are able to give that the patient is happy for you to give us can really make a difference in terms of what that recommendation might look like going forward. And Korori, I absolutely understand what you were saying earlier about considering the person as a person. Everybody's circumstances are different, and we acknowledge that, but we have no idea necessarily what that looks like in terms of the patient sitting in front of you. So you are the best person, and we say the same thing to our case managers. You are the best person to give us that information. We don't have, so the health and disability, regional health and disability teams do not have client contact. There's way too many clients and far too many of us. So we work via the case managers and the likes of yourself. So if you have someone that's in distress, certainly contact us and have a conversation about what that looks like for that person, and then we can work from there.
Yep. Just thank you, Heather. Just really quickly on that note as well, I was just thinking when you were chatting, Heather, that it can be really, really difficult for whānau to navigate big and complicated systems like ours. Like, we totally hear that. And we have some integrated projects around the country that are working brilliantly in terms of navigation. So things like Kera Toitu and our Rangamahi programs, they're not available across the country yet, hopefully one day. But in terms of at a practice level, I'm wondering if some practices might have scope to kind of nominate a practice champion who might dedicate a little bit of time to getting their heads around the supports and services. They could meet with our local health and disability coordinator, and they could kind of take on that role if there are whānau who really need some support, whether it's a HIP or a health coach or a healthcare assistant that you might have sitting within the practice who may have a little bit more time than your GPs and nurses, I'm not sure. But it would be awesome if whānau could sit down with someone and go through things like the Check What You Might Get tool, and they could link them directly in, to our services as they see fit. So I'm just thinking of a way of kind of giving someone in the practice that extra knowledge about the services that it's really hard to expect whānau to have, because we are a big and complicated beast sometimes at MSD.
Yes, you are. My gosh, I feel like we've all got an experience or an emotion there. But it's great to have you here breaking down some of those components of MSD to us all. Quick question in the chat from someone from an urgent care provider who said, hi, we're an urgent/after hours provider with high patient fees. Will MSD funding be accessible to urgent care and after hours providers?
I guess it depends what kind of funding you're looking at. So we, the only way we fund, in inverted commas, the fees associated with patients going to see a doctor is through our disability allowance. So disability allowance looks at all the health costs that a person might have over the course of a year. So it can look retrospectively or prospectively, and it looks at those costs. And if they meet the income threshold for disability allowance, then those costs get divided up into weekly payments, up to a maximum of $78.40 a week. So if the costs are greater than that, in general, we will cap out at that $78.40 a week. So if, for example, as an urgent care provider, you were the regular provider for that patient, they didn't have an enrolled GP, then yes, we might look at that, but it needs to be regular ongoing costs, so it's not a one-off thing. So it probably wouldn't fit the urgent care after hours model in most situations, but we know that more and more whānau are struggling to get registrations with GPs, so often these services are becoming the kind of default provider. So in a situation like that, it could be put under the disability allowance funding, but I guess that would be a case-by-case basis. Heather, anything else to add on that?
I guess it's mindful to think about things like the one-off assistance. So it might be that, so there is an emergency medical component to special needs grant. It's quite a high criteria. I don't have that in front of me at the moment, and it may be that in exceptional circumstances it may meet that. But as I say, it would be on a case by case. They would need to apply, and then it would be assessed on its merits, each case individually. We often say never, but yes, generally it would be through the disability allowance. It would be the regular ongoing costs.
And just making, I guess, sure that all your receptionists are always checking whether the patients have community services cards and are eligible for them, right? Because then that's going to lower the costs for those patients coming into the sector. Right, Heidi, we're going to turn to you for the next question, which is, what practice-wide initiatives can general practice teams undertake to embrace diversity and address the rights and needs of Māori and underrepresented groups?
Hey, thanks for that, Jess. So looking into the foundation standard, there are some great elements in there that can support practices with these things. And in particular, we've got Indicator 3 and Indicator 4. So Indicator 3 is about Te Tiriti o Waitangi, and Indicator 4 is about diversity. And within Indicator 3, there's the Māori Health Plan. Now, the Māori Health Plan would be a great place for a practice to include their debt management initiative. And by doing that, they would also be collaborating with the community. Just by the sheer fact of putting it in there would kind of encourage practices to go to that next step and look into the community, to other health agencies, the marae, the school, the churches, the budgeting agency down the road, etc. And also, it's a way of monitoring whether the debt strategy, for example, is having a positive impact on Māori rather than a negative one, and what measures might need to be taken to turn that around. So that is one tool that practices could use for this, and the other one is diversity. So that's Indicator 4. So when we think about diversity, we don't often think about our lower socioeconomic groups, and yet they're a really important part of our diverse group because they belong to one of the areas that their health is impacted by the sheer fact that they are in this group. So it's one of the detriments of health. And by identifying that group, the next natural step, of course, is to create initiatives around that, create learnings around that, and support those people in accessing care.
Kia ora, Heidi. Thanks for that. It's great to be able to, two birds, one stone, all of this stuff, isn't it? Make sure that we're working towards those foundation standards as we go through that 3-year journey, and don't leave it to the last 3 months, practice manager team. We're all guilty of being in that camp at some point in our careers. Talking about people within our general practice team, this next question's for you, Nee. What are the roles within general practice which can be pivotal and can bridge the gap in understanding while fostering trust. So what are those roles that can really support with that debt management process? Nee was employed specifically to do this from a general practice, and not all practices have that luxury. But could you talk to us maybe about the spectrum of different roles and people that could take on this responsibility?
Yeah, so pivotal roles in general practice is plural. So it involves a practice-wide approach, no matter which way you see it, really. So whether you see it from the patient journey or whether you see it from the operational side of things, and you just need to make sure that co-payment is received. So a practice-wide approach is needed regardless. So if we go into the specifics, I feel that there's an opportunity here for us to look at, it starts off at finding key people in the organisation, whether they are medical or non-medical, that are passionate about it and that are, I guess, have experienced in it in that way, and actually want to have meaningful conversation and actually have, and just make a difference and actually genuinely care, and who actually believe that you can attract bees with honey instead of, the other way. So yeah, in saying that, so pivotal roles are people like your equity champions, who I feel that are at the moment, they do amazing work and they do quite interesting work, and they're already making change. And I feel like they are an example of a role where they could be, an existing health improvement practitioner or an existing clinical assistant that can do sort of the back office support. Your equity champion could also be your team leader that's managing your nursing team, and also your clinical staff like your GP and other things. I feel that it shouldn't be one role. I guess that's my message. I feel that it should be a group of champions, and it is a wide, practice-wide approach. I guess Kathy talked about health coaches, and I think that's a really good role that you could explore. Key people that are wanting to sort of develop their influential or change management skills, or skills that that they want to progress as a career, that if you're a receptionist or a medical administrator, what's their pathway? Having these sort of skills that could actually empower not only the patient but also empower your staff. And I feel that in order to activate what Kororia says, activate our patients or empower our patients, we really do need to do the same thing with our staff. And I think that's where it lands. I don't have the obvious answer. I think it's not a one size fit all for our practices. I feel that it is about looking beyond our typical traditional model of staff and looking beyond that.
Kia ora, Nee. I think we've just heard about who within the practice could, and so I'm going a little bit off script, Aroha mai, but if we go from the who could do some of this role, Lisa, could you talk to around the what? What does a debt management process look like in your practice? How do you go through your aged payables and follow up with those patients that owe the practice debt?
So we have actually had quite a passive approach to debt collection. I hate that word. But yeah, so basically in the past we have used, like many years ago, we've used debt collection agencies, and it was icky and it was yuck and we hated it. And we actually stopped doing that because we weren't getting anything out of it. It was horrible. It was unpleasant. We found it caused barriers. So we haven't done that for quite a long period of time. We try to encourage people over the phone. These conversations are hard to have at the front counter. So while personally I would prefer, I mean, I haven't done reception for a while, but I would prefer to talk to someone kanohi, face to face. It's not always possible just because of the environment. There's always other people around, and you don't want to embarrass anyone or cause shame. So unfortunately, a lot of these conversations are happening over the phone as they're making appointments. We make it very clear that their appointment does not hinge on cash changing hands. That's not a thing. For us in health, and I'm sure it's the same for everybody else on the panel and also watching. We didn't get into it to be debt collectors or to take. We're in it because we care. So while we have to do it, it doesn't come easy to us. It doesn't come easy. So basically, we're trying to get them over the phone, encourage them to start an automatic payment. A lot of the kōrero about it back in the older days was, if you're in credit, we can pay your prescriptions, but of course scripts are free now. So because we've got a pharmacy on site. So, we can put whānau members on that account as well. So we try to encourage people to see the benefit of it. But certainly we don't do barriers here. Our kaupapa right from the start, 30 years ago when we used to be Kaiti Medical, was healthcare for all. We don't design our practice. If you want to be enrolled, you can be enrolled with us. And it's a sticky and crunchy topic that obviously, as you can probably tell, I find very difficult to talk about. But in the current environment, at the end of the day, it's also not going to be beneficial for our community if we're down the plug hole. So, tricky.
Absolutely. It's a dynamic, and I remember being that practice manager with the debt collectors and being like, no more, because you're right, the cost and the effort does not outweigh what you get back from it. So I do think that there's a little bit of analysis practices can do for their own benefit in that space. But you think about the unintended consequence that places on somebody as well, with all of that pressure of knowing that you've got a debt collector coming after you for some medical appointments, when if you could pay that. And I think that we've got to remember this most of the time, is if people can pay it, they will pay it. People aren't not paying their general practice bills because they just don't want to. I mean, none of us want to pay any of our bills, but we do it because it's the right thing. So if people are carrying debt, I think we do need to approach it with that empathy that you've talked about, and that consideration of people are coming to us from a really hard place, and what can we do to support them? What other avenues can we tap into in that space? And also really thinking creatively around your different revenue streams. If they're coming in with long-term conditions, is there some long-term condition funding that you can access to support them with their consultations? Are they coming in for something else, that there's another service line within your PMS that you can accredit that cost to? And being quite creative around the way in which you allocate your funding from. Most PHOs support practices with flexible funding, and a lot of the time that flexible funding is to support debt management for patients. So making sure that you've got a really good approach and strategy for distributing that across all of the patients that really do need it, and then making a real effort to analysing that and creating some understanding of what that data is. I think that we've covered off some really awesome stuff so far, but to just add some lightning to the fire, Claudia, the next question is for you, and we're going to talk about how do you balance the necessity of maintaining cultural sensitivity and empathy when addressing outstanding practice bills with patients. Lisa's talked about it, I've talked about it. From a patient, what do you want from us? What do you want from your provider?
Look, I guess there's it's kind of like trying to put into 5 minutes a whole day kōrero, but I'll give it a whirl. I guess in terms of the cultural sensitivity and empathy, particularly being wahine Māori, I'm culturally Māori, but I also have my own culture. So I guess in terms of approaching this, I wouldn't want someone to come into it going, I've done my cultural sensitivity training, so I'm feeling really, kind of get up for this, because actually being culturally sensitive in my world is seeing me as an individual, in my individual circumstance, my individual, kind of, like I love the kōrero and the whakaaro that was shared earlier around understanding why someone goes to the GP. Is it reassurance? Is it because they're managing a long-term condition? Is it because they feel confident because they don't have to pay, that they're in more of a proactive approach rather than waiting till it's really acute? And so the cultural sensitivity stuff, I think, is connection with a person first to understand what's going on for them, and then being able to use what's front of mind for them to leverage change so that we're both getting to the win, right? So I really kind of, for me, it keeps coming back to connection, authentic connection, and those trusted relationships. And I think too that in this space, we, in order to, and I get that it's really busy, right? I get that it's really tricky environment. I get that there's a lot going on. So I also want to put the disclaimer out there that we're all human, we're all having a human experience, and the ability and capacity to be able to do this well will vary minute by minute, day by day. But as a guide, I guess I would try to step back for a second before I undertook one of these calls and say, how am I going to connect with this person so that we can explore the thing together, right? Sometimes little tip, I have a little poinamui that I hold on to, and I just give myself a little centering before I pick up the phone and make an awkward call, because that's what works for me. I've also got Modi spray or whatever it takes, whatever it is that works for you, do that. And just try and find that connection with a person, because when you're in that space, they've got an empathy for you too. They understand that your position's difficult as well. They don't want to see anybody in a tricky position. And I guess the other thing that I have around this is that often when I'm sitting very much in my person whānau space, and someone says to me, what do you think? I go blank, right? Like I'm just like, oh, I can't think. Because actually what I do is when I'm the recipient of what's often awesome care, I'm feeling that. So if I'm using words like I feel and this is how it makes me feel, then talk to me about how I'm feeling. Don't talk to me about how I'm thinking, because there's a disconnect there that I think helps us say the same things, but we're crossing over each other when really we're trying to get to the same place. So I guess in terms of cultural sensitivity, to invite that empathy, we kind of have to get down to where that person is, which is most often a feeling place, right? So I guess I'm trying to get there. Did that help answer your question? I guess would be a better question, Jess.
Yeah, kapai, absolutely. And I think if I broke down what you just said, if I'm a receptionist or a practice manager or someone within the practice about to make that phone call, taking a deep breath, putting yourself into their shoes, and also unleashing your vulnerability in that conversation too, starting off with, I really don't want to be making this phone call today. Like, I'm really, this is a really tough, don't go in with, oh, this is great. But going in with the, I feel the hardness of this conversation, and I'm really on your level wanting to work through a plan with you and bringing that to the conversation. We're going to wrap up, team, with a few quick fire questions, which I'm hoping the audience are going to keep popping into the chat, because there's some really, really good ones in there. Nee, this might be one that you can lean into from your examples working in PHOs, but do you know of any examples of how the flexible funding model looks for some PHOs? I know I've worked in a couple where practices were given a certain amount of money per month, and that was for them to use for their discretion, whether that was high using populations or whether that was for your practice had really big palliative kind of care and your palliative money didn't quite cut the mustard, you could lean into that. So it was quite flexible depending on the practices, I guess, health need within the population. But what we did find was a lot of the time that that money was spent on patients' financial hardship. But Nate, do you have any other examples of PHOs?
I honestly don't. I know that it's not something that it's not usually encouraged in that space, but the word flexibility is probably not the right word for it. I guess the creative way of spending that money is probably the better way to describe that money that's being put through. I don't know what other PHOs are doing, but from my experience is that the deliverable or the initiative itself that drives the outcome of that patient is where the money should be spent. So the process improvement behind it, the quality improvement behind it, the equity initiatives behind it, if done well, naturally that will help with the debt and the preventative sort of work behind it. It's not a quick fix. It's something that happens over time, being done well. So it's not a case of paying, lining, or or paying the old debt off with any particular money, because I don't want to go on record to say, and I don't support that. It's to say if you're actually using that money so that it's being it's used for the patient. It's centered around their care, centered around the initiatives and their outcome, and the way you deliver that healthcare should impact the operational behind it, so the quality improvement behind it. Don't know if I actually helped answer that question with you, but debt management is used in a tool if you're trying to, say, for example, promote a really cool health, down the road, and you want to get everyone on board and do like a shared care plan. You would make sure that co-payment's 100% sort of thing. You're getting them in the door, you're talking to them about budgeting advice, you're talking to them about all sorts of holistical support that is killing 5 birds with 1 stone. So that's the sort of initiative I'm sort of talking about. Thanks,
Nee. Yeah, I think it's variable across the country in terms of different funding pools that come from PHO. Your best bet is to talk to your PHO and talk to them about what flexibility there is in the different funding lines that you receive from them in that space, and just note that there is variability of that across the country depending on how your PHO cuts up your service delivery putia. It's not a right way or a wrong way. They're all just different, and they're all just providing a different service, generally focused around the community in which you're based in and the population in which you're serving. High user health cards. I remember this being the hardest, most longest, most manual process back in my practice manager day. Lisa, are they still a thing? Are people still using them? Are we underutilizing them? What's the deal?
I'm excited about this one because we've actually just put a process in place with the high user cards. We have a clinical administrator and a kaiawhina who are actually, well, she's a kaiawhina with our community nurses, but we're actively pursuing that funding. I think it's really highly underutilised, but we've actually got some community nurses that deal with our long-term conditions patients, our top 5% long-term conditions patients. And a lot of them are actually eligible for a high user card. So we've actually gone in first with that group, and we've also run a rest home service with a nurse practitioner and nurse practitioner intern going into the rest homes. And so those patients, just by the nature of their illnesses, are eligible for high user cards as well. Yeah, and so we've just started doing that, and we've gone up, gosh, I think we've gone up 150 in about 6 months. So, but that's if you've got the luxury of dedicating the resource to it. It has been a really tricky thing to, it was a 6 week to 8 week wait to get anything back. It was all done through the post. And now we've got a little bit of online action, which is actually quite good. So yeah, I would really encourage practices to just take another look at that, because I know a lot of people have given up on it, but just get hold of the Te Whatu order and just see if maybe there's some other ways, because you can actually get them through the NES now, which is, they go straight into the system. So yeah, there's a lot of improvements that have happened without our knowledge, and we've only just realised that. So
yeah. Kia ora, Lisa. I'm so glad that it's now online, because my gosh, I remember those paper forms and they had to be signed by the oh my gosh, wow, that's like bringing back some memories. Hey guys, we're going to close out with a final question for everyone. It's the one that's come up a couple times in the chat, and is probably one of the more gnarly ones around debt management. And it talks to, what are your suggestions for whānau that transfer out and have large debt? Likewise, patient dies, has large debt. What are we doing in these situations that are generally really awkward, really difficult? The likeliness of getting this funding is minimal, but can hold a real big financial burden at a general practice. So pretty big one to end on. I'm going to just put my 2 cents in there. Have a fundraiser once a year, have a sausage sizzle, have a whatever you need to do within your practice, run a raffle, run a whatever, do a once a year annual fundraiser for your practice, and put all of that money into a pot that sits alongside for this type of event, where you've got patients that transfer out with big debt, or your patients that die with big debt, or you've got really high needs patients that need lots of care and lots of intervention and need a little bit of support. If I was to have one thing that I do within my practice to support with that, it would be a little fundraiser. It doesn't have to be high energy or high effort. It could just be a raffle or two running in the back of your practice for a couple months and just generating a little bit of revenue to support with that initiative. So we're going to close out. Quick fire, 30 seconds. What's your initiative? And then we'll close out with a karakia. Kathy, what are you going to do in your practice?
Kia ora. Well, hopefully not let it get to that level is what I would say to start with. So the preventative thing all the way. So identify them early, wrap around the support and information, and try and make sure they've got what we call at MSD, full and correct entitlement, which means are they accessing all their right benefits, disability allowance, child disability allowance? Are people in their whānau accessing those, so we can maximise the income coming in and hopefully help them getting to that huge level? But I love your idea, Jess, of the Bunnings sausage sizzle. I think we should approach Shane Ratty. Let him know that's what it's come to, folks.
Right, absolutely. Meanwhile, we'll keep advocating for an uplifter capitation, okay, team? It's on the cards. It's on the cards. Nee, what are you going to do in your practice?
Oh, it's a loaded question, because you can do a lot. I mean, I'm gonna probably repeat myself here, but it is, I think there's an opportunity to bring in the community, pay it forward. I think there's a lot of people out there that are wanting to help out. I think we can be confident and actually ask them, put it on social media, put it on LinkedIn, and be like, hey, look, we really want to settle this account for some really high needs family. And if next time you're in, while you're having a sausage at Jesus Sausage, so they'll come in and do a little bit of donation, or a page where you could do like give a little page or something like that. If the debt is a lot, from a practical point of view, I would take it a case by case. If you look at a practice that's been transferred out, if it's a small debt, just leave it. If it's recent, leave it, because there is a chance that the patient may come back and then you can address it then. I don't think you should be spending too much of your time and resources on something so small. What is small? Again, you can define that as an organisation, whether it's worth your time and their time. If the debt is more than 100 days old, I can guarantee you will never get that back. So yeah, bring on the sausage sizzle.
Love it. Lisa, what are you guys doing to address these transferring out patients?
So transferring out patients, you can only try so hard before you realise you're not going to get it back. However, we do have a lot of patients move back to us, so that's an opportunity to have that conversation when people move back, to say, look, you know, you've had this debt with us, we've written it off because that's generally what we've done. Let's start new. Let's start, you know, and just give them the opportunity to start fresh. As far as patients that have passed away, I'm not going to be pursuing any grieving families. That's a simple write-off, not touching that with a 10-foot barge pole, quite frankly. So yeah, we do write off a lot of debt, but we kind of put it down to the nature of things, to be honest with you. So we wrote off just over 40 grand last year. And we do carry a significant amount of debt, because that's the business we're in. Is it sustainable? No. But that's why we're here having these conversations now, to make sure that, you know, we are sustainable in the future, but not at the cost of anyone's mana.
Aye.
Mm.
Kia ora, Lisa. And for context, Lisa is from one of the largest general practices in New Zealand, in Aotearoa.
20,000.
Yeah, I think you are the largest, aren't you?
So it's so are we perfect? No, because being this size, it's hard to be perfect. But do we want to be better? Yeah. So, and I think most practices are in that position as well. It's about wanting, you know, not thinking you're doing things perfectly. We're going to do these things for the next 20 years, but always be willing to evolve.
Yeah.
So.
Kia ora. Heidi, what have you got in your little bag of tricks?
Well, obviously I don't have a practice, but an idea that sprung to mind would be to forget about those debts. Of course, the transfer out and deceased debts, I agree, 100%, no point wasting your energy there. How about hitting up a local industry and getting sponsorship? And you could then, in your newsletter, your practice newsletter, you could acknowledge them or have their advertisement, or, you know, do something like that so that they get a little bit of exposure as well, and they know that they are contributing to the community.
Love that. Beautiful. Heather, what do you reckon?
And I would just tautoko what Kathy said around the full and correct entitlement. I sit next to our health and disability coordinator, and I hear the calls that she has from practices around this very topic. I would encourage you to either talk to your patients, to your people, around their bill at an earlier stage. So we've had queries around patients that have had quite high hundreds of dollars worth of debt, and the intent would be to get onto that before it gets too high, because at some point that won't be manageable. If they're already, if you know they're receiving disability assistance, then that's probably a bit of a hard conversation around, you know, when we're aware that that's you already be funded for that. If they're not already receiving disability allowance, we'd encourage you to contact us, and we may be able to look at the current amount and then add in disability allowance going forward, so that it doesn't get to that point again, and or have a conversation. So having a conversation both with the patient, but also with the regional health and disability team to see what we can, if we're able to assist at all.
Kia ora. Thanks, Heather. Hey, Lisa, just in the chat, there's a few people wanting to know how to access these high user health cards. Are you able to send that information through to Nee and I, and we can send it out to all the people that attended today?
Yeah, just let me run it past Michelle, and because it's all written down. Cool. So I do have to acknowledge Anne-Marie, who's probably watching us, and Lisa Ray, who actually put a fantastic procedure together, and I think it's probably, it's great. It's just doing amazingly. So yeah, just let me double check it with my boss. And I'd be happy to do that if that's okay.
Thank you so much. Absolutely. And Claudia, What ideas are you going to bring to this kōrero to finish us off? I'm sure you've been blubbing away all these beautiful innovations that practices could be doing, and we're all hanging out to hear what they are.
Well, I guess the thing that occurs to me and is catalysed by the collective whakaaro being shared is that we've moved on from the place where we thought they're the doctor and this is a general practice and it's all about that doctor thing. And I view my GP service as more of a community service now. So therefore, as a community member, I want to know what's going on with my community service, the way I do with my Surf Lifesaving Club and my Lions Club and all of those things. So actually making those things visible in your reception area, allowing the community to have some awareness of that stuff. This is where we are up to in terms of supporting whānau that can't necessarily support themselves at the moment. Would you like to help with this? You can choose to offer $19.50 extra on your bill, which pays for one whānau visit for a community services card holder, or $35, and so involving the community and supporting the community and allowing them to see what the issue is so that they can contribute in a way that's realistic for them, I think is a wonderful idea. And potentially having a Ronald McDonald hand, stick it on the practice window or something, so that you can kind of, I'm doing this because you looked after my mum before she passed, or, and connecting back into that empathy that we have. Community is community, right? So how do I experience that and at the same time support the services that support us? So I guess that's what's been catalysed by all of the wonderful whakaaro. Kia mihi, kia koutou. Kia ora.
Kia ora. Love that. Communities have the solutions, right? And they have the answers. Working with your communities to support you in that space is such a beautiful way of concluding our webinar today. Just because I miss practical, just budget for debt. Budget for debt every year. There should be a certain level of debt, just like we do with every other organisation, service, product organisation. We do budget for a level of debt within our environment. So no different for general practice. Figure out what you can afford within your budget and make sure that there is a slight variation for it in there, because the reality is that it's going to happen and you're going to have debt. If you're a completely debt-free practice, would love to talk to you about what you're doing. But I think the thing is that everybody, we had 140 people in this webinar at one point. That just shows you that this is an everybody problem. Everybody is feeling this. Everybody is trying to work through solutions to support with such a common problem. And what we need to do is just, have a little bit of self-empathy in there. Think about what we can do as an organisation and as a general practice to get over the line with that. And if that means budgeting a 5% total for debt, whatever it is, figure out your numbers within your kaupapa. But I would always encourage a practice to budget for debt at the end of the year. Keep the questions coming through. Kelly's just asked for some connections to MSD, so Kathy and Heather will pick those up for you, Kelly. But do take down in the chat both Kathy and Heather's email addresses, and you can email them directly. You can always contact Ni and I. We're here to support and awhi as we go, as is Heidi from the college. So do feel free to link into her with any of your quality standards, kōrero pārtai. I'm going to close this out with karakia 10 minutes over. It was such a good chat. We had to go slightly over. Aroha mai. But we will close out with karakia, and we look forward to seeing you at our next webinar. Kia tau, kia tātou katoa, te ata whai o te tātou ariki a ihu karaite, me te aroha o te atua, me te whiwhina tahitanga ki te wairoa tapu, ake, 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 āmene. Ka kite koutou.